Welcome to the webinar, Interconnected Risks, Unified Care, Screening for CKD in the CKM Era. My name is Cecilia Lo Wong. I'm a professor of medicine at the University of Colorado, Anschutz, and also a member of the CKM Guidelines Committee for the American Heart Association. Joining me are Dr. Jen Trujillo.
Hi, everyone. I am a professor and the Associate Dean for Education here at the University of Colorado, Skaggs School of Pharmacy and Pharmaceutical Sciences. It's great to be here.
Thank you. And also Dr. Ian DeBoer.
Hello, my name is Ian DeBoer. I'm a professor of medicine at the University of Washington in Seattle, Washington. I'm a clinical nephrologist. I practice at the Puget Sound VA Medical Center, and I direct the Kidney Research Institute here at the University of Washington, where I perform research in diabetes and chronic kidney disease. Happy to be here.
Thank you both. We're very happy to have you both here. This is the first webinar in a four-part series to advance healthcare professional knowledge and awareness of cardiovascular, kidney, metabolic, or CKM conditions. Here is this quick disclaimer slide. So just that the recommendations and opinions presented by our guest speakers may not represent the official position of the AHA and American Stroke Association. And just so that you know, after the presentation, we'll have a Q&A session to answer your questions. So please feel free to type in your question during the presentation in the Q&A section of your screen, and we'll answer them as time permits at the end. And here are our faculty disclosures. And now I'll hand it over to Dr. Trujillo to begin the presentation.
Thank you, Cecilia. So to start, the learning objectives for tonight are to identify and appropriately screen people at risk of chronic kidney disease with UACR and eGFR and recognize the disparities and social drivers that impact CKM and CKD screening and outcomes. The outline that we're going to try to follow, I'm going to kick us off and talk about the description of the AHA-CKM syndrome framework, including its staging system. And then Ian's going to talk about identifying people at risk of CKD and appropriately screening people at risk using a UACR and an eGFR. And these three things are really, for this particular webinar, highlighting how impaired kidney function and albuminuria serve as indicators of elevated cardiovascular and metabolic risk. Then we're going to move on to quickly talk about some disparities and social drivers that impact CKM and CKD screening and outcomes. And we're going to spend a good amount of the end of the session going through some clinical cases and having a good discussion about those. So to kick us off, I'm going to start off with that description of the AHA-CKM syndrome framework, including the staging systems. So the AHA Presidential Advisory on CKM Health was published in 2023, and you can see that it was developed by a large interprofessional group with a wide array of expertise. I think the genesis really stems largely from two items. Number one, the urgent need to really address cardiovascular, kidney, metabolic health holistically rather than treating each condition in isolation. And then also major therapeutic advances that now really offer meaningful reductions in cardiovascular mortality. So this work set out to define CKM syndrome, to propose that staging framework, outline approaches to screening and risk prediction, and then provide guidance on the prevention and management. So let's start off with that first step of clearly defining what CKM syndrome is. This is a consensus definition formed by experts with a wide array of expertise, and it's considered to be a health disorder. It is attributable to a connection of four major things: obesity, diabetes, chronic kidney disease, and cardiovascular disease. And for this CKM definition, cardiovascular disease is defined broadly. It encompasses heart failure, atrial fibrillation, coronary heart disease, stroke, and peripheral arterial disease. And importantly, it includes both individuals with existing cardiovascular disease and also those that are at risk for developing cardiovascular disease. So again, it's notably a syndrome or a systemic disorder, which is a collection of related signs and symptoms indicating a common underlying pathophysiology rather than a formal diagnosis. And the syndrome leads to multi-organ dysfunction and high rates of adverse cardiovascular outcomes. As I mentioned in the last slide, it includes both individuals at risk for cardiovascular disease due to the presence of metabolic risk factors, chronic kidney disease, or both, as well as individuals with existing cardiovascular disease related specifically to metabolic factors or CKD. I think it's important to note that CKM syndrome is influenced by unfavorable conditions for lifestyle and for self-care that may be resulting from policies, from economics, or the environment. So this figure illustrates an overview of the stages of CKM and shows the potential progression from stage 0, where there are no risk factors for CKM syndrome, up to stage 4, which indicates clinical cardiovascular disease in CKM syndrome. We'll go through the details of each stages in the next few slides, but you can see the progression here. Our goal is really to screen for CKM more routinely so we can identify individuals in these early stages to help prevent and slow the progression onto the later stages. So stage 0 being no risk factors, stage 1 being that excess or dysfunctional adipose tissue, stage 2 really starting to see those metabolic risk factors become present and chronic kidney disease, stage 3 escalating up to subclinical cardiovascular disease, stage 4 landing us in the clinical cardiovascular disease space. Before we dive into the stages in a bit more detail, I want to pause to highlight a few responses to the question of why now? This advisory comes at a moment when we have tools now to intervene earlier. The goal is really to identify those high-risk individuals before irreversible organ damage has occurred. Really also to unify how we define and how we talk about CKM. And then also to align our clinical care, our policies, our public health around a more preventative approach. This advisory, I think, reflects a shift in thinking. Instead of treating cardiovascular, kidney, and metabolic diseases separately and often late in the game, it really encourages early identification of risk. It also allows us to all have a unified definition of CKM and really a coordinated approach that spans clinical care, policy, research, and public health. And then lastly, it also acknowledges the many social drivers of health and the need for really prevention across the life course. So let's go through the stages in a little bit more detail. So CKM syndrome stage 0 are those folks that have no CKM risk factors. So individuals with normal BMIs, normal waist circumference, normal glucose, normal blood pressure, normal lipid profile, and no evidence of chronic kidney disease or subclinical or clinical cardiovascular disease. Stage 1 then is identified by excess or dysfunctional adiposity. So individuals that are overweight or obese, have abdominal obesity or potentially dysfunctional adipose tissue without the presence of other metabolic risk factors and without the presence of chronic kidney disease. So we can identify those folks by evaluating a BMI. So anyone with a BMI over 25, we can look at the waist circumference over 88 or 102 centimeters in women or men, or a glucose level in the pre-diabetes space. So a fasting glucose of 100 to 125, or an A1C between 5.7 and 6.4. Then we move on to stage 2. This is where individuals will have metabolic risk factors and chronic kidney disease. So our metabolic risk factors being hypertriglyceridemia, hypertension, metabolic syndrome, or diabetes, or someone that has chronic kidney disease. And you think about those five options that can identify metabolic syndrome. You're looking for the definition of metabolic syndrome being 3 out of those 5 or more, waist circumference included, HDL, triglycerides, blood pressure, and fasting glucose. Then we move on to stage 3. This is folks that have subclinical cardiovascular disease in CKM. This can be either subclinical ASCVD or subclinical heart failure. This is in individuals that would already have stage 2 CKM, so those that have that excess or dysfunctional adiposity, other metabolic risk factors, or CKD. So thinking about subclinical ASCVD, that's where we're looking at a coronary artery calcification score, or subclinical heart failure that would be diagnosed through elevated cardiac biomarkers. In addition to those two pieces of the definition, you could also be categorized into stage 3 through risk equivalence of subclinical cardiovascular disease. So that could be either very high risk chronic kidney disease being stage G4 or G5, indicating an eGFR less than 30, or through some type of high risk through some type of risk calculator. And then finally, stage 4 CKM are folks that have clinical cardiovascular disease in CKM, so coronary heart disease, heart failure, stroke, PAD, or atrial fibrillation among those individuals that may have been earlier classified in stage 2 or 3. So those with the excess adiposity, other CKM risk factors, or CKD. And then it can be further defined as either 4A or 4B, depending on the presence of kidney failure or not. And then in addition to that progression in pathophysiology and risk, we have represented in the staging construct, several other factors enhance the likelihood of progression along CKM stages and are associated with increased risk for cardiovascular and kidney failure. There's a long list here. I'm not going to read through all of them, but certainly includes chronic inflammatory conditions, some of the high-risk demographic groups, high burden of social drivers of health, other things like family history of kidney failure and family history of diabetes that we can think about as being risk-enhancing factors for CKM syndrome as well. And with that, I'm going to turn it over to Ian so he can walk us through some screening processes for identifying those folks at risk for CKD.
Thank you so much, Jen. That was fabulous. We'll turn now to identifying people at risk of chronic kidney disease or CKD as one central component of the CKM syndrome. And I'll start with explicitly defining what is chronic kidney disease. A simple question, but we don't want to overlook this. CKD is defined as persistent abnormalities of kidney function or the presence of kidney damage that is present for at least 3 months. So there are many ways that there can be evidence of kidney damage, but the key one that we usually focus on is albuminuria or elevated urine albumin urine albumin in the urine, or reduced eGFR as one of many potential kidney functions that can be reduced. It is important that these are confirmed prior to diagnosing chronic kidney disease to differentiate, for example, a chronic kidney disease with low eGFR from an acute kidney injury. And as we'll show, there are many reasons to diagnose chronic kidney disease when present, including, importantly, influence on treatment. But another one is for risk stratification and prognostication. And what's shown in this table here are associations of eGFR with cardiovascular outcomes. These particular data come from a cohort study that has combined multiple populations together. It's a very large cohort study and shows adjusted hazard ratios for eGFRs of 60 to 89 and 45 to 59 compared to a higher normal GFR of 90 to 104 mils per minute. And what you can see is that there are progressively higher risks of myocardial infarction, stroke, heart failure, and cardiovascular mortality, 1.6 to 2.4 fold as you have progressively lower eGFR. So this is one reason that eGFR has been included in the prevent equation. eGFR and, as you'll see, also albuminuria are strongly associated with cardiovascular outcomes. Who should be targeted for CKD screening? Well, first of all, the most common causes of chronic kidney disease are diabetes, hypertension, cardiovascular diseases, including heart failure, and also people who've had a history of acute kidney injury or acute kidney disease are at high risk of developing chronic kidney disease. So these are the largest, most important populations for testing for the presence of CKD. There are other populations and other risk factors that can be considered for CKD testing as well. Those include environmental exposures, and there's a condition called CKD-U, or CKD of undetermined etiology, which is prevalent in Latin America, India, and Sri Lanka. That is probably related to environmental exposures. There can be structural problems that lead to chronic kidney disease, including recurrent kidney stones, systemic diseases that cause chronic kidney disease, exposure to nephrotoxins, and very importantly, also family history. We're learning a lot more about the genetics of chronic kidney disease, and family history clearly is a risk factor for chronic kidney disease that may push you to test for chronic kidney disease. There are others here as well. Again, to focus and most clearly, hypertension, diabetes, and cardiovascular disease are the patients who should be most highly targeted for chronic kidney disease evaluation. And how do we do this? The most important message here on this slide is that to assess for chronic kidney disease, you need two tests. One is the eGFR, and the second one is the urine albumin to creatinine ratio, or UACR. And when you're testing for chronic kidney disease, you should be attaining both. The GFR is estimated usually from serum creatinine. Serum creatinine, of course, is a widely available and commonly tested analyte, and it can be converted to an estimated GFR through validated equations. It is a good estimate of kidney function. It is not accurate in everybody, particularly people who have extremes of body size, either very muscular people, very small people, in which creatinine generation differences may lead to differences in serum creatinine and alter the relationship with GFR. In these cases, also testing cystatin C to help estimate GFR can be useful to come up with a more precise GFR estimate. Albuminuria is a critical complementary test to assess for kidney damage. It's most easily done using a spot or random urine sample. There's a lot of talk about should someone use a first voided urine or a 24-hour urine collection. The most important thing is to measure it. So to measure in the sample that's available at the time, dividing the albumin concentration by creatinine to calculate the urine albumin to creatinine ratio accounts for differences in dilution and leads to an interpretable biomarker that can be used to diagnose chronic kidney disease. How often should testing be done for chronic kidney disease? Well, in CKM stages 0 and 1, it's important to estimate GFR at least 2 to 3 years for stage 1, or at least every 5 years for stage 0. eGFR can be then used in the prevent equation to estimate cardiovascular risk and think about preventive strategies. For CKM stages 2 or more, so that's everybody with hypertension, diabetes, metabolic syndrome, or subclinical or clinically apparent cardiovascular disease, both eGFR and albuminuria should be assessed at least annually. And if either eGFR is low or urine ACR is high in a persistent way, that is indicative of chronic kidney disease. Why is it important to measure and test for chronic kidney disease in the setting of cardiovascular disease? Well, this nice conceptual model from the AHA CKM Presidential Advisory explains that fairly well. It shows the interconnected nature of cardiovascular risk factors, cardiovascular disease, and chronic kidney disease. You can see that hypertension, dyslipidemia, metabolic syndrome, and diabetes, adiposity, inflammation, oxidative stress, and insulin resistance all contribute to the genesis of chronic kidney disease. Chronic kidney disease has specific mechanisms promoting atherosclerosis, myocardial remodeling, and fibrosis. And there's a two-way direction of interactions between CKD and cardiovascular disease, where cardiovascular disease can continue to promote chronic kidney disease progression and acute changes in kidney function. These conditions are all tied together, and so the testing for concurrent conditions, and in particular testing for CKD for people who have cardiovascular disease, is very important. What does it mean when abnormal test results are obtained for chronic kidney disease testing? Both eGFR and albuminuria are independent and additive risk factors for cardiovascular events. They reflect risk and call for thoughts on intensifying therapy, and they are all both directly linked as well to specific drug therapies. The KDIGO, or Kidney Disease Improving Global Outcomes Staging System, which I'll show in the next slide, does combine both eGFR and albuminuria to diagnose and stage chronic kidney disease. And the identification of either abnormality does lead to significant upstaging of CKM syndrome and changes in management. So here is the KDIGO heat map. It shows in the cell contents risk for both cardiovascular events and CKD progression, with green being lowest, followed by yellow, orange, red, and dark red. You can see that risk increases progressively as albuminuria increases from left to right and as eGFR falls from top to bottom. Using the scheme, chronic kidney disease should be categorized both on GFR and albuminuria, as well as the presumed cause of chronic kidney disease, if that's known. You can see also within the cells, the numbers indicate the recommended times per year to consider testing or monitoring for chronic kidney disease. And you can see treatment for chronic kidney disease as part of the CKM syndrome is recommended for any degree or stage of chronic kidney disease. So Jen, I'll hand it back to you to talk about disparities and social drivers that impact CKM and CKD screening and outcomes.
Thank you, Ian. We'll just hop right into the next slide. So social drivers of health are really the non-medical risk factors that have a prominent impact on CKM risk. They are, of course, interconnected. They influence one another. We think about societal drivers, including economy, education, access to healthcare, community drivers, including neighborhoods, workplaces, schools, exposures. And those environments and systems may shape relationships and social networks, which can influence behaviors like diet, physical activity, sleep, tobacco use. Importantly, social drivers of health play a really significant role in the development of cardiovascular risk factors, as well as cardiovascular morbidity and mortality. And all of these layers interact then with individuals' biological predisposition, genetics, early life experiences, stress, other physiologic factors to really influence CKM syndrome and its outcomes. The takeaway for me is that social drivers of health impact CKM outcomes, which makes it critical to screen for and identify social drivers of health in all patients as that first step to moving on to addressing those social drivers of health. There are numerous screening tools that exist to survey things like financial strain, education literacy, personal safety, perceived needs for assistance in addressing social needs. Here are some examples that are highlighted in the CKM advisory report. The first one is the health leads. This assesses essential domains such as food insecurity, housing instability, transportation challenges, things like that. It's about 10 to 12 questions. It takes less than 5 minutes to complete. And I think it provides a really practical clinic-friendly screening toolkit focused on really identifying common unmet basic needs and then pairing that screening with resource referral workflows. So it emphasizes integration into clinical care to really kind of try to close the loop by connecting patients to community-based services. I think this one is really, some of these tools are more designed for research purposes. I think this one is really designed for clinical implementation and not just data collection. The next screening tool is through the Centers for Medicare and Medicaid. Also assess similar drivers of health, housing instability, food insecurity, transportation problems. It's also a 10-item screening tool with 5 core domains. It should take less than 5 minutes to complete as well. It was developed more to support large-scale health system use and policy-level integration. It kind of reflects a shift towards recognizing social risk within, say, value-based care models. The iHelp screening tool is the next one. It is 14 to 24 questions, again, assessing needs across 5 similar domains as the previous 2. It is a structured social history framework that is really commonly used in medical education to help train clinicians to think a little bit more broadly about social context during patient encounters. And it's just a little bit more conversation and educational in nature rather than a formalized reporting tool. And then lastly is the We Care screening tool. It is also 10 questions, assesses economic stability, education, family context. It was initially developed in a pediatric primary care setting to screen for social needs and then link families to community resources. So there are several validated screening tools that exist to help clinicians identify patients' unmet social needs. They vary a bit in terms of scope, purpose, and setting, but the goal is really to get some type of screening in place in your practice setting so you're better able to identify folks that need support and then ultimately link patients to those meaningful resources based on what their individual needs are. With that, I think I will turn it back over to Cecilia to start us off with our clinical case discussion.
Terrific. Well, thank you so much, Jen and Ian, for going over the definitions of CKM, the framework, and then also how to screen for CKD, the definitions, and then the social drivers of health. So now we'll try to use some of the information that you gave us to go through a couple of cases. So let's start with the first one. So case study 1, I'm just going to go through some of the details, and then I have a couple questions for you towards the end. And so this is a 42-year-old male who's white and then works as a security guard. He has commercial insurance through his employer, and he lives in an urban area. A couple of other important points about his social history are that he's divorced, he reports some stress from work, and then also having to caregive for a sibling with special needs. He does walk during work, but otherwise he says that his work is pretty sedentary. He's otherwise sedentary, so doesn't do any planned physical activity. And because of time and other considerations, ends up eating a lot of processed foods and takeout meals. So his medical history is really just significant for obesity with a body mass index of 35. And his family history includes the fact that his father passed away from a myocardial infarction at the age of 45, and his mother has a history of type 2 diabetes. So at this current visit, this is his annual wellness exam. He tells you that he has been having 6 months of right knee pain while he's walking. And he last saw a primary care provider 2 years prior when he had a sinus infection. So his vital signs show blood pressure of 128/78, heart rate of 74. His weight is 212 pounds. And then he had some fasting labs drawn before this annual wellness exam that included a glucose of 97, an A1C of 5.9%, serum creatinine of 1.1, and a GFR of 73 with an LDL of 132 and triglycerides of 146. So maybe before I go to, so this is one question for you is there anything missing? And Jen, I'll direct this question to you first. Is anything missing here that could help you with CKM syndrome staging?
I think a couple things come to mind. I mean, I think that knowing this patient's BMI and looking at the A1C, I'm already putting him into a specific stage and wondering if maybe I need to increase that to the next stage. So I guess I'm thinking about wanting a little bit more information related to metabolic risk factors. So we have the blood pressure there, but we don't have a list of medications or a problem list. So I'm curious to know whether the person has a diagnosis of hypertension, if the patient is on any medications for hypertension. I would also be curious to see if the person's taking any medications for diabetes. So I think those could definitely help. As cardiovascular disease risk calculator score, always a benefit for me when I'm staging.
Yes, absolutely. I completely agree. I think there is some information that's missing here. And I think knowing a little bit more about his other medical history, whether or not he's taking medications. So, is his blood pressure and are these numbers, in the setting of being on medications for any of those conditions? Ian, anything else you can think of that you might want to know about this patient?
Jen's list is quite good. We already know that this patient has at least stage one CKM from their BMI alone, but they also have other cardiovascular risk factors with the elevated hemoglobin A1C and the prediabetes range and the family history, as Jen noted. So my antenna are up as well. And of course, I'm a nephrologist. So when you have a hammer, everything's a nail. And I'd like to know about kidney risk factors, nephrotoxins, NSAIDs, and a little bit more about the kidneys, looking in the urine, ideally, even if not necessarily recommended at stage one. As Jen said, we're sort of wondering whether there's a stage two component here, and I think that could be useful.
Absolutely. And I guess I'm going to just take this opportunity to ask you, as a nephrologist, when you look at this eGFR in this patient, do you get worried about an eGFR of 73?
Well, that's a great question. eGFR is a great test, and it's quite precise in the low range. In the high range or the normal range, greater than 60, it is a little bit less precise. So I don't know for sure what the 73 means. I also don't know whether that's changed over time. So if this is somebody who has maybe a little bit more muscle and is making more creatinine, that could account for the slightly elevated creatinine and slightly lower than expected eGFR. If it's been stable over time for years, that might just be this patient's eGFR. If it's been declining over time, that would make me worried and suggesting a change in kidney function over time. So those are some of the factors that go into my head. This is an instance where a cystatin C could be useful. If the eGFR is for some reason an overestimate, cystatin C could come back and show an eGFR that is maybe less than 60 in the CKD range, which would be important. So those are all the thoughts that go through my mind, Cecilia. And I think the short answer would have been yes. I think the 73 is a good and useful estimate. But I think I would also be looking at the trajectory and thinking about a cystatin C.
Okay, perfect. Yeah, because this is really just a snapshot.
Right.
Okay, so um, uh, we see that this patient has obesity, has that elevated A1C, so in that prediabetes range, and don't know what the UACR is, but has a family history of cardiovascular disease at a young age. And then we probably could use some more information, as Jen mentioned, but I think that we can be pretty comfortable that this patient is stage one. So perfect. Any other comments about this case?
I guess I have to just comment on the social drivers of health just to do my due diligence that,
You want me to go
this
back a little
is
bit?
no,
Yeah.
you don't need to, but
Okay.
I think it's
Okay.
just such a great, it's a great case study to support that this could be a this is the right opportunity to screen for social drivers of health when somebody's in those earlier stages, and we can try to prevent all of those metabolic risk factors from occurring to begin with, and certainly from progressing. So here's someone that has maybe newly diagnosed prediabetes and has identified some drivers that can impact healthy eating and physical activity. And we saw some things in the case that alluded to increased stress and some potential drivers that could negatively impact that trajectory onto diabetes and other disease states. So I think a good solid screening for social drivers of health would be really helpful.
I agree, Jen. And no matter what we are thinking down the road for pharmacotherapy, we know that lifestyle therapy is going to be important, and social determinants of health are going to be critical drivers of what he's able to do in terms of modifying lifestyle.
Yeah.
Absolutely. Yeah, and I think there are so many preventive things that we can do here. As you mentioned, we can see that he's already experiencing some arthritis and some limitations to physical activity. And so there are different interventions that we could be thinking about, such as lifestyle interventions and then maybe some pharmacotherapy. So maybe let's move on to case study 2. Okay, so this is called the missed opportunity. This patient is 53, female, African American, and works as a cashier and has public insurance, Medicaid, and also lives in an urban area and has limited access to primary care. She's divorced and lives with an adult daughter and reports stress also from work, and caregiving as well for an elderly mother. So she reports being sedentary and also has a diet high in processed foods because she doesn't have time for meal prep, and reports minimal exercise. Her medical history is significant for hypertension for the past 10 years, for which she admits to being not optimally managed. And so her normal or her average home blood pressure ranges from 145 to 155 over 85 to 90. And her type 2 diabetes was diagnosed 8 years prior. She takes metformin 1 gram twice a day and is taking semaglutide 0.5 milligrams injected weekly. She also has obesity. Her BMI is 32, and she is on atorvastatin 20 milligrams a day. And so her family history is significant for her father dying of an MI at the age of 62, and her mother has CKD stage 3. So at this annual wellness exam, she says that she feels generally well, but she has some mild ankle swelling and increased nighttime urination. And she last saw her primary care provider about 18 months prior. And her blood pressure, 148 over 86, her heart rate's 82, her weight's 182. And we have some initial labs that were drawn a couple of days before the visit that include a fasting glucose of 138, an A1C of 7.6%, an LDL of 88, and triglycerides of 210. So let me maybe start with Ian. So what do you think is missing in the table for a comprehensive evaluation of CKM status?
Well, first of all, this is another outstanding case that shows a couple of things. One, again, the importance of social determinants of health. But another is the complex interrelated nature of care for these patients. And you can see there are a number of risk factors here that need to be addressed and could be optimized, and how these are going together. And of course, key in my mind is thinking about how these risk factors are addressing kidney disease. And does this patient have chronic kidney disease? They're at very high risk. They have long-standing diabetes and hypertension with suboptimal control. So that's certainly one thing I would want to know about, and would affect my prescriptions in terms of pharmacotherapy as well. So I think that's highest on my list. Of course, I'd also like to know a bit about the challenges that this patient has had in the past for controlling risk factors, because clearly we'll want to try and address some of those.
Absolutely. And any thoughts from your side, Jen?
Well, I agree. This is like, missing the CKD part of CKM. So definitely identifying or, getting some lab values for eGFR and UACR would be I think really important. And I'm also very curious about the exploring the history of suboptimally managed hypertension, what medications have been tried in the past. And also, I work in a adult diabetes clinic, and primarily that is my focus, is the diabetes population. So very, curious to know this person's history from a diabetes medication standpoint. I'm reading that there's just limited access to primary care. We see so many folks that maybe get started on appropriate therapy, but never get appropriately titrated to a dose that we know is more effective. So I would be curious just to get more information about those histories.
Absolutely. So let's see if we can get some more details. So as you both pointed out, it's important to get some labs to also assess her kidney function. So we have some additional labs. So we see that her eGFR is 45, her UACR is 150. And so any thoughts at this point in terms of, does this change your assessment of her risk?
Yeah, and absolutely. And probably this is chronic kidney disease. Both the eGFR and the UACR are abnormality and are abnormal. And thank you for the case designer for getting both of those. That's the most important thing here in my mind. Um, we do, of course, want to know whether this is persistent. Maybe there are old values that we could refer to see if there's a history of albuminuria, proteinuria, or preceding eGFR. If not, we do want to confirm, but not wait too long to confirm. This is a situation in which we know that having both low eGFR and albuminuria increases cardiovascular risk and increases risk of progression to kidney failure. And so we do want to start instituting therapy pretty quickly. And this does, I think, have direct bearing on the medications that we would want to prescribe to reduce cardiovascular and kidney risk.
Absolutely. And quick question, Jen. So knowing that her labs or her medications included metformin at that maximum dose and then the semaglutide at zero point 0.5 milligrams weekly, and then also thinking about, the fact that she has type 2 diabetes and any gaps that you see in her therapy, in her medication therapy.
Well, absolutely. I think we have the opportunity to maximize the semaglutide in terms of both glucose improvement and from a BMI perspective. I think metformin, is reasonable to continue. From, a blood pressure perspective, I'm very curious about medication history, but that's a big gap. I think, controlling glucose is absolutely important from a microvascular complication, but controlling, lipids and blood pressure become even more important when looking at the patient holistically. I also think that the CKD data that we're seeing now too begs the question about an SGLT2 inhibitor as a component of the regimen as well. At least here in our state, those medications are well covered under Medicaid. So I think that that could be a very reasonable addition as well.
Yeah,
Absolutely. And
and
oh, go
from a
ahead.
yeah. But may I, Cecilia?
Yes, please. Yeah, please go ahead.
From a nephrologist standpoint, I agree with all of those, in particular the SGLT2 inhibitor. And the ADA, KDIGO, other organizations do recommend SGLT2 inhibitors for people who have type 2 diabetes and CKD at any level of eGFR or albuminuria. If one is off, if both are off, or the other is off. So this person does have an indication for an SGLT2 inhibitor. It would be expected to reduce kidney risk and heart failure risk in particular. And the way I think about this, is the SGLT2 inhibitor is unlikely to have a lot of effect on glycemia at this point, particularly in eGFR 45, where the ability to increase kidney glucose filtration is low. I don't expect much effect on A1C. but it's really the organ protective effects of the drug that we're looking for that have been proven in clinical trials and are the basis of these recommendations. So it's not so much a risk factor motivated decision as a sort of an outcomes motivated decision for that particular drug. Both are important, of
Absolutely,
course.
completely agree. And maybe one last point or two to add before we move on to the progression of this, because we find out more about what happens. Um, the question of, why isn't she on a statin? I feel like there are many situations that people um, might put people in a position to not be on a statin, but of course that would warrant a discussion at this visit, and then thinking about whether or not that metformin dose needs to be decreased. So lots of things to think about. And I think for her, she has a lot of different conditions that are increasing her metabolic, her CKD, and her cardiovascular risk. So she has type 2 diabetes, she has obesity, her LDL is not she doesn't have any statin therapy on board. She has markedly decreased kidney function, as has been mentioned. And then she has elevated UACR. She has her uncontrolled hypertension and the significant family history. And so, what stage of CKM would you say that she is? That was something that I didn't ask.
I think she meets stage 2 by the diabetes, dyslipidemia, hypertension, and CKD. She has all 4 components of stage 2
True.
CKM, but I don't see stage 3, at least yet. Yeah.
Right.
Okay, perfect. So stage 2. And then a few years later, unfortunately, she presents to the clinic for chronic disease management, and we find that the blood pressure is elevated at 150 over 89, and the weight is 185. And we have these following labs. And so the fasting glucose one is 198, A1C of 9.6%, eGFR is down to 29, and UACR is 300. And you can see the LDL and triglycerides there. And so, what's going through your mind now? So maybe Jen, I'll start with you.
Well, I think what's first going through my mind is we missed our opportunity. So well named case there, Cecilia. It just seems like such a shame if we were not able to really address some of those comorbidities a little bit earlier. The reduction of the eGFR at this point and the increase in the UACR, I'm interested to hear Ian's perspective. If you think about those pillars of addressing CKD and type 2 diabetes together in the CKM world, you're thinking about that backbone of ACE inhibitors or ARBs, SGLT2 inhibitors, potentially the addition of GLP-1 RAs, and then finerenone. And I think once we get these eGFRs that get a little bit lower, I think starting any of those medications in a safe way to not become overly problematic with the acute issue and insult on the kidney, I think is something I'm interested to hear your perspective on, Ian. I think the A1C, is extremely high as well. So this just shows this progression over time when we're not addressing things at the earlier stages, and there's a lot of work to do right now, full court press, really, in terms of addressing where she's at now.
And Jen, I fully agree. And this was a missed opportunity. We never learned how the hypertension was management, but a RAS inhibitor should have been part of the regimen, particularly given the albuminuria earlier on. I'll say that just 10 years ago, really for these types of patients, all we had for treatment were RAS inhibitors, and the prognosis was not good. And at this point, we would start counseling about dialysis in this stage of chronic kidney disease. Now, I agree. This is more of a all hands on deck. There's still time. There's still possibility to help preserve kidney function and reduce the cardiovascular risk that comes along with chronic kidney disease. And I'm thinking of the same things that you are, Jen. The importance of pharmacotherapy here, really RAS inhibition, SGLT2, GLP-1, and considering mineralocorticoid receptor antagonists as well, to really maximize kidney protection and cardiovascular risk reduction.
And I guess so this what should we do now question is there's so much to do, but how would you prioritize? Like what would you do first? So maybe Jen, I'll throw that to you to start us off.
Well, I think one of the first things so from a pharmacy's perspective, maximizing the medications is where, my brain goes. And I'm in a diabetes clinic, and at that 9.6, I would really want to target that aggressively upfront. But just looking at this case where um, we identified that they had access issues to primary care, and then we're seeing this person a few years later, I think that care coordination and coming up with a plan for improved access to care so that there are more touch points than seeing someone every 2 years, I think might be the most critical piece. The medications work great when you have access to them and when patients take them and get titrated up to sufficient doses and get monitored carefully to ensure that there aren't any adverse effects. And that requires more frequent touches and more support.
I would completely agree. Ian, what would you choose to do first, or what would you prioritize?
Right. And we're talking about combination therapy here and how to optimally institute combination therapy, for which we have some data, but we don't have clear guidelines about how to do this. And I like Jen's approach. She's looked and she's identified what are the most pressing needs for this patient now. Where am I going to focus now? And I think that is the best approach. Can you start all the classes of medication that we just mentioned and a statin all at the same time? Well, it could be done. There certainly is a risk with multiple classes of medications that lower intraglomerular pressure, those are RAS inhibitors, SGLT2s, MRAs, that you could cause an acute kidney injury. And that has to be something that is worried about. And I think it's important to point out that while we need to be better about implementing these good therapies in populations in general, an equally important consideration is continuing those therapies. And we know now that even patients who start kidney protective and cardiovascular protective therapies, they oftentimes discontinue them. So I worry that loading somebody up with too much all at once without the support that they need, financial support, follow-up, et cetera, that Jen refers to, is not a recipe for success. So I think we've identified that we need to make a number of changes. We would like to make them quickly. We probably can't make them all at once. So arranging a care plan is important. For me, I agree with the hemoglobin A1C being a target in the GLP-1. I also, if they're not on an SGLT2 inhibitor yet, I think that's really foundational, and that's what I would prioritize. And in fact, if the patient has access, you could probably do both of those things at the same time.
Mm-hmm.
But Cecilia, I'd like to ask you too, from a cardiology perspective, where would you start? Because there are different perspectives here.
Yeah, I think that there are so many fires here. Kind of choosing the biggest fire is probably the main thing. And of course you both have mentioned this is having a conversation with a patient, trying to figure out how to fundamentally, help her access care and be able to see her more often, have a care plan. But probably the first couple of things would be doing something about the diabetes and doing something about the blood pressure, maybe the most important and highest impact would maybe be what I started with.
I
But I think,
I was also thinking too, that blood pressure would warrant, potentially two medications to start right out of the gates. And if you were thinking about starting an ACE inhibitor or an ARB, along with, sometimes I worry about starting an SGLT2 inhibitor when the A1C is significantly high because you lead to such significant glucoseuria, and which could cause some, you know, orthostatic hypotension, things like that. So I tend to address the blood pressure in different ways early and address their glucose early, wait for the A1C to come down a little bit, and then add the SGLT2 inhibitor from that organ protection standpoint. So I guess if I had kind of an order of operations, I would want the SGLT2 inhibitor to be on board long term for sure. But I might not go for it right at this moment based on that high A1C. I might just hold off a bit.
And I think that's completely valid. So there are some different approaches, and then of course the priorities of and preferences of the patient are going to be
Yeah,
another thing, and
absolutely.
that's often an important. I mean, that's always an important discussion.
Yeah.
So I think what we've identified here is that this is really, a more advanced stage patient. So with that low GFR, with that markedly elevated UACR, she's at a stage 3 at this point. So really a lot of issues to deal with. And so thank you for those case discussions. And we have a number of different questions. So I wonder if we could move to the Q&A. And what I'll do is um, let's see, I think that a couple of questions. So maybe I'll start with a case specific question. And so this is, I'll maybe give this to, I guess, to Ian to start. So in this case, would you prioritize an injectable GLP-1 to cause weight loss, lower blood pressure, lower A1C? What do you think about that, starting with a GLP-1?
Is in reference to the prior case
I
or
think
in
it's that
general?
second case. Yeah, I believe so.
Yeah. I really liked our discussion, and there really are multiple ways to go about this, and it is a shared decision-making approach with the patient, to be sure. I do think an injectable GLP-1 would be indicated. It's great for weight. It's going to be the most effective of what we discussed for glycemic control. It is kidney protective, as we know from the FLOW trial. So I think that would be a good agent. I actually would be comfortable starting an SGLT2 inhibitor at the same time, and that's in part because with the eGFR of 29, I expect little or no effect on glycemia because of the low GFR. So there are, I think, those are, can the patient have access to both those medications? There are lots of questions that come up, and those then have to be discussed with the patient. But I do think a GLP-1 would be great, and that's, I think, what Jen focused on as well.
And I think one of the other thoughts to add to that in terms of the GLP-1 is just thinking about how long it can take for the effect or the glucose lowering effect of GLP-1s. So depending on how quickly you want to lower glucose, it may not lower glucose quickly enough. So just something to keep in mind. So I think we can't really predict um, the how quickly people lose weight, whether or not people can tolerate. I mean, there are all these different issues to also consider with the GLP-1s, just to add on to. But I think in general, this it would be a beneficial class to think about.
Absolutely. Good
So
point. Take some time to titrate that up. So that's an important note. Yeah.
Well, right, this patient was on, 0.5. So
Mhm.
definitely if they're gonna be on it, you want to maximize the impact. So with that in mind, I would absolutely be comfortable increasing that dose and maximizing it while also starting an SGLT2 inhibitor.
yeah, and I think there's a great question here about, and I think this is the question for Ian. So the prevent risk calculator is great. Can you comment on I think what they are asking here is instead of making UACR optional, make it mandatory in the calculator.
Well, it's a great question. I love that question. And we didn't talk a whole lot about prevent today, but eGFR is included in the base prevent, but there is an option to add albuminuria as well. It doesn't markedly improve the statistical efficiency of the equation, and I think that's why it was not included in the base. In addition to making it more accessible, but absolutely, patients who have an indication for albuminuria testing, you should test it and you should include it in the equation. Certainly doesn't hurt. And it's important to note that even if it's not included in the prevent equation, albuminuria can be an indication for pharmacotherapies as well, whether it's an SGLT2 inhibitor or adding an MRA, for example. So the albuminuria testing, I love the spirit. Yes, we should measure it more. yes, you absolutely should include it in the prevent equation when you have it, and so I think that's a fabulous question.
There's one, maybe time for one last question. So I think this last question about a normal weight patient with elevated creatinine and an SGLT2 be used for kidney protection. So Jen, I wonder, are there data for SGLT2 inhibitors and kidney protection in patients who have normal weight?
Ooh, right off the top of my head, I think that data for SGLT2 inhibitors are in patients with diabetes, and people, um, yeah,
And people with
people
CKD,
with
without
CKD,
diabetes as
but
well.
without
Yeah.
diabetes.
Yeah.
Um,
So I do think that there was no BMI minimum for any of those trials. So I think that it would be they would be appropriate, and it could be CKD actually with or without diabetes.
Yeah, I agree. There's unlike GLP-1, there's no weight specific indication for SGLT2 inhibitors, and their effects on weight are much smaller, of course. But they are indicated for people with type 2 diabetes, of course, as Jen said, who have any aspect of chronic kidney disease. They're for heart failure, of course, and albuminuria. So if people have albuminuria, even without diabetes, the threshold we use is 200 milligrams per gram or more. Without diabetes, that's an indication for an SGLT2 inhibitor. So maybe a reason to consider an albuminuria test in this patient to help with that decision.
Thank you both so much for this great discussion. We are at time, so thank you for joining the American Heart Association for this webinar, and stay tuned for the next webinar in the series. An email will be sent out to you with instructions on how to claim credit. Thank you both to Dr. Trujillo and Dr. DeBoer. It's been great talking with you.
you too.
And you.